Welcome to echocardiography lecture series. With the advancement of technology, echocardiography has gained a lot of diagnostic abilities. In this lecture, we will dive into advanced techniques. So grab your coffee and let's begin. Welcome to left side chamber quantifications, part 2, where we're going to discuss advanced LV contractile function assessment, left atrial size and function assessment, and assessment of aortic root and ascending aorta. In the beginning, we have to understand the orientation of myocardial fibers. If you're looking from the apex of the heart, you have subendocardial fibers. So if this is the muscle here, the apex, you have subendocardial fibers that starts here. And you have different fibers. The mid-layer fibers are here. And you have subepicardial fibers here toward the outside. So the subendocardial fibers will run in a direction resembling the right-handed helix, going all the way to the base of the heart. The subepicardial, the outer most fibers, the subepicardial fibers will run the opposite direction, which is the left-handed helix. And also in the other side, they will continue as the mid-layer fibers, which will run in a circumferential manner and then join the subendocardial fibers. This different orientation of the myocardial fibers will give us different motion of the heart during systole. It will give us longitudinal motion, it will give us radial motion, as well as circumferential motion. Those different motions of the heart will give us the ringing effect, like squeezing a cloth to remove all the fluid within. The same thing happens to the heart. So we have circumferential motion, where we can now measure the circumferential strain. We have longitudinal, which is like vertical motion of the heart, where we can now measure the longitudinal strain. Radial strain is horizontal motion of the muscles and thickening, where also we can measure the radial strain, and also we can measure twisting, and I will explain those in the coming slides. Strain or deformation are the same thing, and they refer to the percentage of change of the myocardial length. So this is the baseline, we call it L0, and this is the final length, which is L1 of a segment, myocardial segments. So how we calculate strain or deformation? It is the final segment length minus the initial length, which is L0, divided by the initial length, and it is in percentage. We will note that by doing that, we are dividing, let's say, centimeter over centimeters, and this is why the strain has no unit. Strain, we call it unitless. Unitless. So let's say that the initial size is 10 and the final is 5. It will be like this. The final, which is 5 minus 10 divided by the initial, which is 10. Okay, so it will be minus 5 divided by 10. It will equal minus 0.5. Then you time it by 100. So the strain for this one will be 50 or minus 50%. Strain rate is easily calculated. So it is the rate of deformation. By definition, it is strain divided by time it took from L0 to reach to L1. So if the strain is 50% or minus 50%, and it took the heart 2 seconds to reach from here to here, so the strain rate is minus 50% divided by 2, and the answer is 25% minus 25%, and the unit is 1 per second. Okay. Proceeding now on how to measure the strain and strain rate. We have many ways to do that. One of them is the tissue Doppler, and tissue Doppler was used historically. Now it's not the standard way of measuring strain and strain rate for many reasons. Reason number one, it is angle dependent. So you have to align your probe in a way it is parallel with the motion of the tissue. So you can measure here, but sometimes you cannot measure other type of strain like radial strain here because you're not parallel to the motion of the tissue. The other thing, it requires a very high frame rate reaching up to 100 frame per second. Okay. And also it has a poor signal to noise ratio. But how we measure strain with tissue Doppler imaging? It is simple but smart way. First, we need to specify 2 areas and measure the velocities on those 2 areas. Let's say area number 1, we measure velocity 1. Area number 2, we measure velocity 2. And we know the distance between them is L0. It is usually 10 to 12 millimeter depending on the vendor. So it's a pre-specified length. Okay, then we need to measure the velocity gradient or the difference between the 2 velocities, V1 and V2. Okay, simply if the velocity is not changing, if you multiply by time, you get the displacement or the distance. However, V1 and V2, they are not constant. Maybe at the beginning of systole, they will start somewhere here, and they will go up in the middle of systole, and they start going down toward the end of systole. So we need to measure the average velocities. How to do that is to integrate it with time. So now we integrate the velocity gradient and we multiply it with time, and we get the displacement. And this is done automatically by the machine. Okay, now we have the displacement, which is L1 or the final length. We just divide it by L0 and we get the strain. Strain rate is derived here from velocity gradient without integrating with time. So we measure the velocity gradient here and we divide it by the initial length, and we get the strain rate. Strain rate, now we can, the other way, we can now measure strain from strain rate. If we time integrate the strain rate, we will get the strain. So there are many ways to do that, and luckily the machine will do them automatically. One would ask why we don't use the velocity only in order to determine the LV systolic function. Like, let's say, why I should use 2 velocities here and then use the velocity gradient. Why I just don't use the V1 only and check if V1 is normal, then systolic function is normal. And this is a valid question. But the answer is, let's imagine this. You have a segment here, this segment, V2 segment, is akinetic, is a dead segment, and V1 is a normal segment. Okay, so when this segment contracts here, when it contracts, it will pull this segment here, V2, along with it. It will pull it. So the segment here, let me clear this. The segment here will have a velocity, and this segment, because it's tethered to this segment, it will have exactly the same velocity. So let's assume the velocity here is 10. It will pull this segment here at the same velocity, 10. So velocity gradient here will be 0. 10 minus 10 is 0. So strain will be 0, strain rate will be 0. So this is why using velocity only to determine LV systolic function is not enough. We have to use the velocity gradient and therefore strain and strain rate. Okay, so strain rate, how does it look? Usually it has a negative, initial negative deflection here during systole, because we have to understand also, because it is shortening. When the segment is shortening, you will have a negative strain and strain rate. When it is lengthening, increasing in size, you will have a positive deflection. So initially we will have a negative deflection here, indicate that the segment is shortening during systole. During diastole, we have opposite positive wave, and usually there are two waves in an opposite manner to the mitral Doppler inflow, which we will see in the diastolic lecture. As technology advanced, now we can measure strain and strain rate by a technology called Speckle tracking. Speckle tracking is, if you look at the myocardium segments here and then you magnify it, you will see a texture. This texture is unique and is caused by scatters from the ultrasound reflection. The software then will follow this segment and keep tracking of these segments. So if you have two segments, let's say segment 1 and segment 2, you track them during systole, and then let's say by end of systole or peak systole, you'll have this is segment 1 and this is segment 2. Then you will know exactly the distance between them. From this equation, here is L0, here is L1, you can easily calculate strain and strain rate. This technology is not angle dependent. Therefore, you can measure longitudinal strain, radial strain, circumferential strain, and from this also you can measure twist. And we will see this in the coming slides. One of the ways to present strain result is using the bullseye model. In this model, you have the 17 segment model here, and you have the peak systolic strain of each segment. And as you can see, because this is normal, you have it negative. Okay, so then the software will average the longitudinal systolic strain from all 17 segments, and the result will be called average peak systolic longitudinal strain. Normal, it is usually vendor dependent, but usually minus 18 is considered normal. More negative is considered normal. I mean, minus 19, minus 20% is all normal. But let's say minus 15, this is considered abnormal result. Besides the bullseye here, we can present strain by either waves like here. And as you can see, the color, each color will represent a different segment from here. This is different segment, and it's represented here by a wave or a line. And if you have all the lines going all the way down at the same time and then up all the way at the same time, it is considered synchronized. This is a way to measure dysynchrony also in some of the diseases where you have one line going up, the other lines going down, like what we will see in left bundle branch block. The other way is to use something called curved M-mode. So imagine that if you straighten this line here, or this, you straighten this orange line, make it straight, and plot it against time, you will have something similar to this. So this segment here is presented here, and this segment here is presented somewhere here. This segment here is presented here. So this is called curved M-mode. Okay, and in this curved M-mode, the normal pattern is something looks like a red carpet. You have a red in the center. We call it a red carpet pattern, indicative of normal longitudinal strain. Radial strain and circumferential strains are obtained from the short axis view here. And because it is thickening, if you look at this radial strain, let's say this is in diastole and this is in systole. So this segment here is thickened during systole. So L1 is bigger than L0. So you will have a positive strain, and you will have a positive deflection here. This is the radial strain. And now, because thanks to the Speckle tracking, we can easily measure it directly by this technology. Now proceeding to twist and torsion. Since now we can measure the circumferential strain and also we can track each segment of the heart, we can know their rotation and the degree of rotation. If you're looking at the heart, if you're looking from the apex upward, if you're looking from down upward, the apex is rotating during systole in a counterclockwise manner. And it is given this rotation in positive degrees because it's counterclockwise. The base of the heart, on the other hand, it's rotating during systole in a clockwise manner, and it is given a negative degree of rotation. The difference between the base and apex is the twist. So let's assume that the apex has rotated positive 20 counterclockwise, and the base of the heart has rotated negative 20. The difference between them will be 20 minus 20 or negative 20, and the result is 40 degrees. So the twist, just let me clean here a little bit, the twist here will be 40 degrees. This is the twist. Now if you want to know that the degree of rotation for each unit of length, for each segment, we will divide this 40 over the length between the base of the heart and the apex. So from here all the way to the apex, and we call it L. So 40 divided by L will give us torsion. And this is how we calculate the torsion. Shifting gear now to more or easier topic, which is left atrial size. Similar to LV size, now left atrial size can be measured utilizing linear method or volume. And again, the volume, we can measure it utilizing the area length method or the method of disc. And again, as usual, method of disc is more accurate because it does not assume any geometrical shape of the cavity. Speaking of linear measurements, the way to measure the left atrium in a linear manner is first we choose the parasternal long axis view, and then we freeze at end of systole where the LA is at its largest size just before the mitral valve opens. So it's around 1 to 2 frames before the mitral valve opens, and we measure it at the level of the sinuses, aortic sinuses, leading edge to leading edge, outer to inner edge, in a way perpendicular to the long axis of the left atrium. And this is called the anteroposterior dimension or diameter. And it is not recommended to be measured alone because it does not really reflect the size of left atrium accurately. In many occasions, there will be a normal AP diameter, but the LA is dilated by volume wise, which is more accurate. This is the normal reference values for AP dimension of the left atrium. Now proceeding to left atrial volume utilizing the area length method, we utilize this equation, which is usually embedded in the software. And why this equation? Because this is the equation of the volume of ellipsoid. This is the shape of ellipsoid, which is an egg shape, and this is an assumption of the LA shape. This is why the method of disc is better in volume assessment than the area length method, which is usually will assume a fixed geometrical shape of the cavity. How to do that? We have to trace the LA in two planes, in apical 4 chamber and in apical 2 chamber, and then we get this area here A1 and this area here A2, and the length from insertion point to insertion point, which is the mitral annulus, all the way down to the end of the left atrium. We use the shortest length, L here and L here, and we use the shortest one, we utilize it in the equation. And this is usually done automatically. Whether we are utilizing a method of disc or area length method, we have to trace the left atrium in apical 4 chamber as well as in apical 2 chamber. So it's a biplane measurement. And the way to do it is you start from the annulus, you start from the insertion point of the mitral valve and just trace the left atrium all the way. You have to exclude pulmonary vein here and continue measurement, and then also exclude the appendage. If you see the appendage here or you see it the other side, you have to exclude the appendage, keep it outside, and stop at the insertion point here. Similarly here. So this is coronary sinus. Make sure you don't include it in your measurement, and you trace the left atrium and also exclude the appendage. This is the appendage here, so you exclude it and you stop at the insertion point. Again, you do it at end of systole where the LA is at its largest size. Sometimes the LV and the left atrium, they don't sit in the same plane. So maybe you have to tilt or angulate the probe little bit to cut the left atrium without foreshortening, to cut the largest cut of the left atrium. And this is the normal left atrial volume here. Again, in left atrium, we always have to index it. We don't have normal value for non-indexed. It's only the indexed measurement. And we have mildly dilated, moderately dilated, and severely dilated. Now, proceeding to a more advanced topic, which is the left atrial function. In left atrial function, it is not something routinely we report or we measure. However, we need to understand it very well before we interpret the echo result. So the left atrial has three major functions. The reservoir function, the conduit function, where it will act like a conduit, a passage for the blood from the pulmonary vein and to the left atrium going to the left ventricle, as well now as a pump function of the left atrium, where the left atrium will contract and ejecting the blood to the left ventricle. This is mitral inflow spectral Doppler image, and we can see here the E wave here, which is early diastolic wave, will reflect the conduit function of the left atrium, this velocity. So this velocity is dependent on many factors. It is mainly also dependent on the difference in pressure between the left atrium here, left atrium and LV during early diastole. So if the pressure here is high, or here is low, or here is high in LV, or here is low, so it depends on the pressure gradient between the two chambers, then you will have the velocity of E wave determined. The A wave toward the end of diastole, the atrium will contract and producing an A wave here, filling of the LV toward the end of diastole, and this will reflect the pump function of the heart. So in atrial fibrillation, the LA is not contracting, or it does not produce effective contractile function, so we will have an absent A wave in atrial fibrillation. As you just saw, that the mitral inflow does not tell us anything about the reservoir function of the LA. This is why now we have the pulmonary venous flow. This is a flow from the pulmonary vein. Either we get it in transesophageal echo or transthoracic echo, and if in transthoracic echo, it will be usually the right upper pulmonary vein. And we have many waves. We have mainly three major waves: the S wave, which is systolic wave, D wave, which is diastolic wave, and atrial reversal wave here toward the end of diastole. Sometimes we have S1 and S2. I will tell you about this in a minute. So during systole, the left atrium is still receiving blood from pulmonary veins. So this is the flow going from pulmonary vein to the left atrium, and left atrium will receive and store the blood within. So this is a function of the, or assessment of a reservoir function of the left atrium. And then during diastole, again, the flow of the blood from pulmonary vein will go to the left atrium, to the LA, again also to the LV, all the way to the LV, because mitral valve now is open. So in this, the D wave here reflecting the conduit function of the left atrium. And now we have the atrial reversal. During contraction of the left atrium, most of the flow will go forward to the left ventricle, some of the flow will go backward back to the pulmonary vein. And this is why we see here atrial reversal. And again, this is a reflection of the pump function of the left atrium. Okay, so now in order to understand the S1 here and S2 and the various function and timing of the left atrium, I made this clip and slow it down very much. So S1 here, this wave, when we see it, and it is usually the S1 and S2 separation, we see it very well in transesophageal echo. Usually in transthoracic, we see them fused. So the S1 is atrial relaxation. It is due to atrial relaxation. So here, now look at the left atrium here. Now you have atrial contraction. You see it becoming smaller and smaller. Then you have atrial relaxation. Now the LA become bigger. Okay, so atrial relaxation is S1. During systole, also note here that the mitral valve here is pulled all the way toward the apex, and it will act like a suction. It will suck the left atrium and therefore suck some of the blood from the pulmonary vein here. So now we have S2. Okay, so S1 is caused by atrial relaxation. S2 is by the motion of this mitral flow toward the apex, as well as the coming blood during systole, which is now pushed through the venous system to the left atrium. Okay. By saying this, if we don't have atrial contraction, we don't have atrial relaxation. So in case of atrial fibrillation, where there is no atrial contraction, we don't expect to have S1, and we will have a small S wave, and we call it S blunting pattern, and we will see this in diastolic function assessment. Okay, now proceeding to the diastolic wave here. When the mitral valve opens, we will have this D wave, the diastolic wave. And if you look carefully at the mitral valve leaflets here, you will see them opening first and then become closer to each other to a semi-closed position. Then they will open again due to atrial contraction. So now becoming smaller and smaller. Then atrial contraction, they open again. And this is causing this small reversal wave here. This is atrial reversal wave. Important part of left atrial assessment is the assessment of the left atrial appendage velocity or emptying velocity. This is very important in evaluating for cardiac source of embolism and presence of thrombus. Okay, so and it's usually only done in transesophageal echo, because in transesophageal echo we will have a good alignment between the Doppler beam here and the emptying of the blood from the left atrial appendage. So this is the left atrial appendage, and the alignment here is parallel to the blood flow. Okay, so then we measure it by pulse wave Doppler. We just put our sample volume, and this we will see it in details in transesophageal echo lecture. We put the sample volume here at the mouth or opening of the left atrial appendage. Normal velocity is more than 50 centimeter per second. However, if the velocity is below 20, now we will have a risk for formation of left atrial appendage thrombus. Now, to complete the left side chamber quantification, we proceed now to measurement of the aortic root and ascending aorta. So what is aortic root? So this is the aortic leaflets here, and aortic leaflets usually insert here. This is the insertion in the aorta, and usually they go in the wall all the way here, to the something called ST junction, sinotubular junctions. So we have this tubular part of the aorta here, this tubular, and this is the sinus part of the aorta. So from this insertion here, proximal insertion here, we change the color. From proximal insertion here to the sinotubular junction, we call it the aortic root. Okay. Now, as mentioned in previous lectures, the way to measure anything distant to the valve, to the aortic valve, will be measured in leading edge to leading edge pattern, from outside to outside, from outside to inside, from outside to inside, outer edge to inner edge, or a leading edge to leading edge convention. Okay, so now we have to, after measuring the aortic root, to measure the ascending aorta, usually you need to move the probe a little bit closer to the sternum, or by a little bit tilting the beam toward the sternum to get the ascending aorta in the view. Again, we measure it in the same manner, leading edge to leading edge, outer edge to inner edge. Okay, and not only that, the measurement has to be perpendicular to the long axis of the aorta, here and there. It has to be perpendicular. We cannot have an angulated or tilted measurement. Measurement like this is not accepted. Measurement like this is not accepted. So we need to imagine, or to have an imaginary line of the long axis of the aorta, like this dotted line here, and we measure in a way perpendicular to that line. And those are the normal values of different parts of the aortic root and aorta. Thank you for watching, and our next lecture will be about LV diastolic function assessment.